it's something that's not heart related that is causing the openings in the capillaries to be able to, or material inside of the capillaries to be able to move out more easily. Now, what are some of these things? Hypoxia, severe hypoxia. How can we tell if someone is truly hypoxic? Huh?
A sinus.
A mixed venous blood gas. To look for PVO2 or SVO2. Remember, the artery's only telling me what's available. When the blood gets back to the pulmonary artery, that's when I know if the tissues used it, if they used more than what they normally use. So what does it mean to you when someone has a PaO2 of 52 millimeters of mercury? Huh?
It's mild hypoxia?
I'm going to go ahead and put that over to moderate.
Okay.
Okay?
Sorry, that's what I meant.
That's okay. But the thing is that now I'm thinking that the tissues have a really high chance of becoming hypoxic because there's not enough oxygen there to begin with to supply their needs. Does that make sense? Okay, acute respiratory distress syndrome. Have y'all heard of this? Have you heard it out in the hospital? What do you know about it?
Just something coming on sudden.
Okay, it doesn't have to come on suddenly, but a lot of times it does. And what happens is, whatever causes the respiratory distress syndrome, that leads to increased capillary permeability, and then fluid moves from the capillaries to the interstitial space, to the alveoli, to the bronchioles, and the same cascade of events is going to happen. It's just two different causes.
So, how does the capillaries become more permeable?
In the case of ARDS, it could be aspiration. It could be a toxic inhalation. It could be that the patient's been on 100% oxygen for a period of time, over 24 hours, and now pulmonary oxygen toxicity has started to take place, and that increases capillary permeability.
But how does that do that? Why is it? How does that increase the permeability? That has to do something with the change in pressure gradients.
Yes, and this doesn't answer that question completely, but sometimes what will happen is, talking about pressure changes, is the protein level goes down outside of the cell. So now the oncotic pressure gets down to 10, and the capillary pressure is 15, and now fluid is going to move from the cell, from the capillaries to outside. And I don't know real technically how to answer your question, but the things that come into the body open up those membrane, because you've got ions moving in and out all the time, and it just makes those openings bigger so that more fluid can rush out than what normally should. So the ultimate end is the same, it's just what causes it to happen, if that makes any sense. So with heart failure, it's not increased capillary permeability, it's that the pressure gets so high that the fluid moves out because of a true pressure difference. But with any of the other things, the capillary permeability is really what allows fluid to move out, except in that particular instance when the protein level's real low. How can you tell that it's a that the protein level's low on a patient? Do you know? Nobody's told you this, so I don't know if you would know or not.
Lab.
What lab value?
Yeah, and wouldn't it be urine? Like your urine?
You can look at urine because protein will go through the urine, so a urine sample could be taken. Typically, if you've got an elevated potassium, that means kidney failure, so you're thinking that there may be some protein loss. But I'm thinking more along the lines, have y'all heard of albumin? That is the protein level. And so if you look at the albumin level and it's decreased, then there could be an osmotic non-cardiogenic pulmonary edema going on. And instead of giving the patient normal saline to increase their volume, albumin's going to be a better choice because it has protein in it. It is protein. Does that make any sense? Okay. So inhalation of toxic agents, different pulmonary infections, especially the anaerobic infections, therapeutic radiation of the lungs, and acute head injury can cause a neurogenic pulmonary edema. Any questions? And there's more for non-cardiogenic pulmonary edema. Another big one is lymphatic insufficiency. The lymph's not able to take on the extra fluid that's coming out, so it gets remains in the interstitial space, has nowhere else to go, moves to the alveoli. Decreased intrapleural pressures, I already said oncotic. Overtransfusion is another one that you have to think about. Patient gets a blood transfusion and it goes in too quickly, and patients can go into pulmonary edema very quickly. And I forget there is a term for this.
Decompressed pulmonary edema?
That doesn't sound like the one that I'm thinking about. It's like an acronym. I'll have to look it up. I had it on my mind for a while because one of our students from a few years ago, she developed breast cancer. And she doesn't mind me telling the story, she's given me permission, but she developed breast cancer and had to go, it was stage 4, and she had to go through lots of chemo and radiation, and ended up having to move back to where her family was at. I forget what state, but she weren't able to finish the program because of the cancer, and she's okay now. After going through that. But one of the things is they didn't suspect because she was only 25 years old. So you can't look at people's ages. You can't look at, oh, it's usually this way. If it looks like a duck, then treat it like a duck. You know, go ahead and this is probably what's going on, you know. And so then she had surgery, and they gave her blood, and she went into this. Oh, and I can't think of it, but it was this non-cardiogenic pulmonary edema from the blood transfusion, and they weren't expecting that either. And one of the older doctors come in and said, "This is what's happening," and they were able to treat her very quickly, and she was okay. But it could have went a whole nother way if they hadn't have been on top of it. Yes.
You said it was an acronym?
Yes.
Is it TACO?
Or TRAL. TRAL.
Transfusion associated circulatory overload? The only thing I can find.
What is that acronym?
I found transfusion.
TAC,
What about trolley? TR.
that's it, trolley.
Transfusion-related acute lung injury.
That's it right there, trolley. But good, y'all are, I mean, these are all things that can lead, what you just said could lead to it also. Okay? Trolley, though, that's the term that she said, I went into trolley and she said, and you know, they just weren't expecting it, so,
So it's called trolley.
yes.
Are we mean that for the test?
That may be a good bonus
Bonus
question.
question right there,
Well,
go
it's not a
ahead.
bonus question now. I don't know.
I may still give
That's an
it,
easy bonus question.
yeah, I may still give it as a bonus.
Gotta remember.
Trolley, T-R-O-L-L-Y.
Uh-huh.
You gotta know what it, she wants to know what it means though, spell it
It's just
correctly.
LI.
Say it again.
TRALI.
T-R.
Transfusion-related, no, transfusion-related acute lung injury.
Say 5 minutes fast.
And of course,
Related what?
acute lung injury. And of course, acute kidney failure or kidney inflammation can also cause it.
Maybe it didn't pick it up.
Now, one of the things that you may want to do also is think about an echocardiogram when someone comes in, and we're going to look at the signs and symptoms in just a minute. But